in listen-only mode.
Welcome everybody, this is the third dissertation dissemination webinar, and today we have Dr. Aaron Fisher, who will talk to us about tailoring psychotherapy to the individual client, and he uses very fancy statistics to do that. And you may have seen his publications in, for instance, the Journal of Consulting and Clinical Psychology, and many more interesting work that he's done. Dr. Fisher received a degree in clinical psychology from the Pennsylvania State University, where he studied psychophysiological correlates of mood and anxiety disorders and psychotherapy for generalized anxiety disorders. And he's interested in the development of a person-specific model of mental health research, including identification of predictors of physical morbidity and mortality in psychiatric populations, and the exploration of person-relevant dimensions of psychopathology within individuals. Dr. Fisher is currently conducting a study in the Department of Psychiatry and Behavioral Science at Stanford University on personalized assessment and psychotherapy, utilizing multivariate time series methodologies. So we're very pleased to have Dr. Fisher here to present his work from his dissertation and no doubt also from what he did after his dissertation and share this with us. For those of you who haven't been to a webinar before, I'm going to explain to you briefly how it works. If you have any questions, there are two ways to actually ask those. As you can see, there is a question window, and in this question window, in your control panel, you can type in a question. What you can also do is raise your hand. If you look at the list, there's an opportunity to raise your hand, and you might want to try it. Could you please raise your hand? See if that works. Great. I see a couple people raising their hands. I'm going to put all of those down again. All right, so if you have a question, you can raise your hand so that we can see that you have a question. And if you have a question, we'll open up your microphone. And if you have a microphone, then you can actually talk to Dr. Fisher directly. And you can ask your question. So there will be moments in the talk when there are pauses where you can ask questions. If you don't have a microphone, then you can type it into the question window, and we will read your question to Dr. Fisher. All right, so thank you, and I'm going to give the floor now to Dr. Fisher. Aaron, here you go.
Hi, good morning. Thanks, Kim. That's a great introduction. I do have to apologize that the talk today and the data actually don't come from my dissertation. So it all comes from stuff that's kind of going on now. But it does have a lot of overlap with some ideas that I was starting to formulate certainly in the last few years of grad school. And I will point those ideas out as we go. Just before we get started, Kim used a lot of kind of, perhaps as I hear them read back, unnecessarily big words. There are some stats that maybe you could think of them as fancy or advanced or something like that, but I really want to try today to talk about all this stuff in a way that while we utilize the statistics, that we can understand the concepts in a way that seems applicable and seems, relatively straightforward. We'll see how successful we are at that. So I want to start by providing a little background and rationale around why we might approach assessment and intervention and maybe psychopathology broadly from an individual perspective. Talk a little bit about this idea of temporal dynamics, which, if that's not a term people are familiar with, I will absolutely unpack that, and how when we kind of take a bunch of people in a large sample and average across them, we might be losing a lot of information and time. And then I have some data to show. So I have a study that I'm conducting right now, and it's far enough along. And one of the wonderful things about doing person-level analyses is you can show some nice data analyses, even if you only have a few people who have completed your study. So I'll show some data from some actual participants in the study that I'm running right now. And certainly I think we'll have plenty of time for discussion and questions. And Kim, if there are questions in the middle, we can interrupt this at any point and stop and chat. That's totally fine. So I'm going to try to limit, the jargon or the number of, unfamiliar terms or possibly unfamiliar terms. Idiographic versus nomothetic are these terms that get thrown around a lot in ways of categorizing research into either research about the individual with aims at understanding the individual, measuring the individual, and that's the idiographic, or the nomothetic, which is where we want to measure groups, understand groups, characterize the behavior of groups. And typically, what we do in clinical science broadly, in psychotherapy research, we typically work at a nomothetic level. So we work at this level of groups. I'm sure most or everyone listening right now is familiar with this. You run a study, you get some funding, and then you go out and you want to collect a maximally large sample. We want to get 30, 40, 50, 100 people. And then when we want to look at differences by condition or baseline predictors, how severe people were, or socioeconomic status, or these types of factors, we look at these as group effects. The 30 people in the one condition versus the 30 people in the other condition. One of the arguments that I want to make today is that what we're assuming is a level of sameness, a degree of homogeneity in two major categories. The first is the psychopathology itself. There are a lot of studies out there where, for instance, a colleague of mine, good friend of mine, Sam Nordberg, we were just working on a paper this past week, which will hopefully get out there into the world soon, where Sam took a large sample of all sorts of different diagnoses. And the focus there was less on one specific form of psychopathology or another. But normally, I think it's safe to say, and maybe somebody later can correct me if this is not a right statement, but we typically say, okay, I'm going to look at generalized anxiety disorder, I'm going to look at panic, major depressive disorder, borderline personality disorder. We pick these diagnoses, and once we've done that, once we've brought people in, we've given them the structured interview, and we've said, this person has this diagnosis, we typically dummy code that in our data with just a 1. So all of a sudden we're encapsulating this quite a bit of information about this person, how they function, their level of impairment, all these different things with just a 1 versus a 0. We put them into this category and we make a large number of assumptions about what that category means. And then as we go through the process of treating people and measuring their response in a psychotherapy study, for instance, we're again assuming quite a high degree of homogeneity in the way we're going to go about treating them. But then as we average across them, and this is something I'm going to discuss in far greater detail in a few slides, as we average across them, we really begin to disregard the level of detail that we actually have there to observe about how they really moved through time, one person at a time. So there's a lot of potential variability both in the disorders themselves or the symptoms or syndromes themselves, and then, of course, how people respond to our psychotherapy interventions. So, yes, these things happen within individuals. I recently gave a version of this talk. I won't be talking about this much today, or maybe not at all, but where I connected these ideas to some work I'm doing looking at cardiovascular health, so the health of people's hearts. And a point that I make in that talk is that when we're looking at trying to identify factors that predict a heart attack, right? A heart attack is something that happens in a person. So we get all this group level data, we average across our people, but we want to know this process that happens inside, literally, physically, inside a person. What is it that makes their arteries begin to get blocked? What is it that leads to the actual moment when that blockage becomes acute and the heart is not getting enough oxygen, so on and so forth. Similar argument here, and I think that it's a nice metaphor to track back now to talking about psychopathology and psychotherapy. The experience of behavioral avoidance, anxiety, panic attacks, we can average these over people, but these are, of course, experiences that occur within an individual. And when we are delivering psychotherapy, when we're giving an intervention, and I know in SPR we've got a collection of many different theoretical backgrounds. So I tried to be inclusive here in this slide. Whether we think it's insight-oriented, something regarding behavioral modifications, cognitive restructuring, whatever we believe theoretically to be the actions or specific interventions which are creating change in an individual, I think most of us can agree that change occurs within that individual. And so I would argue that these processes that are of individuals, that we should do our best to assess them within the individuals. And so I want to talk about some methods for doing that. First, I want to talk a little bit about, I want to get at this idea of the heterogeneity in psychopathology. So the DSM, Diagnostic Statistical Manual, which we're right now on the cusp of moving from the 4th to the 5th edition of, we have this system where we say, okay, for a given disorder, there's 11 symptoms, and you need to have 5 of the 11, and you need to have had them more often than not over a period of so many months, and et cetera, et cetera. So there's a real kind of, grab bag kind of orientation to this system. And so for each discrete diagnosis, so for each diagnosis that often ends up as just, like I was saying a moment ago, as just a very simple piece of information in a data set, and even if we're talking about clinical practice, I think there's a parallel there. When someone sits across from someone, it does often happen to say, oh, well, this person has panic disorder. And so there's a constellation of assumptions that we start to make. When the truth is that there is an overwhelming number of permutations that can be met for being diagnosed with an anxiety disorder, depressed disorder. Ken Levy, I should have given him a call and asked him for his slide. He's got a slide that he's used many times. He's presented it at SPR, in fact, with the exact number of permutations that there are in the borderline personality disorder diagnosis, and I can't remember. I'm going to butcher it, but it's hundreds. It's a huge number. It always kind of shocks me when I see him present that. So we've got this pretty notable degree of heterogeneity simply in the way that you can meet criteria for a single diagnosis. So substantial heterogeneity. One of the things that I find, I was going to say most troubling. Troubling is probably too strong a word, but one of the things that I find curious, certainly, is that when we have a diagnosis like this, even if we are very thorough and we say, oh, I'm not going to just assume that this is a category and it means all these things about this person. I'm going to look deeper and say, well, they have this symptom but not this symptom. We don't tend to have tools or use tools that tell us anything about the relationships between those symptoms. So the person has anhedonia, they have feelings of guilt, they have been eating less, feeling, I think of a couple of, they have sleep disturbance, for instance. Okay, so this is a depressed individual. Those are informative points of intervention. So if I'm working with that person, I say, okay, I want to improve their sleep, I want to help them feel a little more hopeful, improve their self-efficacy and self-worth, these types of things. But what if there is one or two of those symptoms that are primary in their experience of their psychopathology, of their experience of their depression? What if it is the case that over time, the variability in their sleep or the variability in their feelings of self-worth drive the variability in the other symptoms? And if you could understand those dynamics, you could have a much more effective and efficient method of targeting that person's functioning in their psychopathology. So what are these relative contributions of a given symptom to the individual's function? It may be that, yes, when you sit across from someone and you give them a skid or an ATIS or a mini or some interview like that, and you say, do you have this experience? Do you have this experience? It may be the case that they say, yes, I have that experience. But it may also be the case that it's ultimately less important to the totality of their experience and how they're functioning. And they may or may not have some insight into that, but we may be able to directly observe that. So I want to shift a little bit now towards try to get us on the path toward talking about these ideas at a methodological level. I want to give a little more kind of rationale for why we might go some of the directions that I'm going to present. And the first is this idea of temporal dynamics, and I've kind of been leading towards this idea that, there are symptoms, for instance, talking about psychopathology, but we can assume that those symptoms exist in time. We take a cross-section. Someone comes into our clinic, someone comes into a research study, we ask them questions, we sit across from them, we give them a self-report measure, and we get a snapshot of how they're feeling and how they're functioning. And and in these interviews, we often do a good job of saying, how has it been over the last couple of weeks? How have you been feeling over the last month? Is this something that's consistent for you in your life? So we tend to have this inclination to try to assess the temporal functioning. But we do also, I feel, we ultimately fail to get at the dependency in people's kind of, what am I trying to say here? So there's I think a much more dense array of dependencies. So it's not just that someone has recurrent depression and they had an episode last year and they had an episode this year, and oh, look at this, it seems like in the late winter you become depressed. Absolutely, that's highly important. But I think it goes much deeper than that, to the degree that when you think of, for everybody listening right now, for instance, each one of us, for instance, we're spread all over the world. For me, it is 9:20 a.m. on the west coast of the U.S., and some people are in having evening time in Europe, and others are in different spots in the U.S. So we've all had different amounts of the day so far. Hopefully everyone had a good day. And we're all bringing to this webinar some amount of positive affectivity, right? We're feeling positively affected to one degree or another. I would argue that, hopefully I'm having, by the way, a good effect on your positive affectivity, I hope. But the degree to which you were feeling positively affective before you sat down at the computer certainly is a strong predictor of how you're feeling right now. The events that have happened to you throughout the day are strong predictors, and those that happened to you the day before, and so on and so forth. And we could look at your level of positive affectivity, negative affectivity, how well did you sleep last night, how are your feelings for those of you in Europe about winding down the day and getting into bed later tonight. All of these things may coexist in a way that's just kind of, they might be orthogonal and just benignly unrelated, but there might be important interrelations between those things at a more kind of, let me say, micro level, in a level that if we want to, we can investigate, and may give us far greater information than simply, have you had this disorder before? Do you feel like you tend to be anxious? And those types of questions. All right. So now this is a little more towards the research end of this, less about the clinical practice, although I do want to track back to this being something that can be applied to any single clinical practice. So again, as I mentioned earlier, when we do psychotherapy research, we almost always want to get a maximally large sample, what we can get our hands on, what we can afford to recruit, and then we use all sorts of methods to look at those samples and how they changed over time and what might have predicted that change. But we're inevitably betraying the heterogeneity in our samples, in the people that we measure. For those of you who use these methods, you might be thinking right now, well, hey, we use latent growth models. We use linear mixed effect models, which are sometimes called HLM models or multi-level models, and we call these models person-centered models. And that's appropriate, and those are wonderful models, and some of you may know I use them myself all the time. The major problem, though, with that modeling is that we allow these what we call random effects. And for those of you who don't use these techniques, you've perhaps heard that term. So the random effect is the way in which the model accommodates the fact that, well, I have 30 people in the model, and they each have their own trajectory. So we say, well, we allow this random effect, which accounts for the variance in the way the individual's trajectory differed from the grand mean trajectory. The problem there, though, is that in order to create the grand mean trajectory that the individual is varying from, we had to aggregate across all the individuals. So this is a really nice figure. It comes from a recent review paper that was talking about just this issue. Let's see if I can use this here effectively. So the kind of the grand mean for this, and you can see I cannot draw a straight line, is roughly there. Let's pretend that's nice and straight. Oh, I lost it. Okay. So this would, if we had this data, we would come out with perhaps might get evidence of a quadratic effect. You see some of these folks do have a kind of a bend and flattening. But we'd most likely get a nice significant linear decline, perhaps a quadratic effect that shows that it kind of swoops and levels off. And then we would certainly have significant random effects for the deviations from the group mean. And here's where this highlighter is actually going to be really helpful. Look at this individual. Have we characterized this individual with this grand mean? We look at this individual here also. Oh, I missed him a little bit here. Got him. Have we characterized this individual with this grand mean? The arguments for aggregating across all statistics is the idea that the non-systematic variations from the effects that you find are simply noise, and that they will vary across individuals to such a degree that, again, that it won't be systematic, that it won't be due to anything in your data, it won't be due to anything that you should have measured or could have measured, or at least that's your hope. But what I would argue, what I'm trying to argue here, the point that I'm building towards, is that HLM models, mixed effects, etc., latent growth models are fantastic models. They're wonderful ways of summarizing data. In addition, they are fantastic ways of characterizing group phenomena. What may happen, though, is in calculating a group effect in a model such as this, in a longitudinal regression model or a growth model in an SEM framework, that trajectory that we estimate, while it may characterize the group, it may be an emergent property, whereby it characterizes the group but does not relate back to any single individual who composed that group. And so never mind, so people often talk about generalizability, and we often worry about does my sample, do my findings generalize to other populations? And what I'm saying is I have another concern. I'm not just concerned about whether my data generalize to other populations. Do my data generalize back to the population from which I calculated my analyses, my results? The problem that I see that may confront us in this regard is, if we are interested in characterizing groups, then I don't see a problem here. But if we're interested in characterizing individuals, then this might present a dilemma. And this relates to this idea, there we go, slide will forward, of this idea of ergodicity. So I just want to introduce this term. I find it to be an important term. I know it's a little jargony, but it kind of doesn't have a simple language synonym or parallel. So ergodicity, it's a condition when you're talking about the structure of the variation in your data. And it's a condition where the structure of your inter-individual data, so the variation between individuals, is equivalent to the intra-individual variation. So why is this important? Well, first a note about, it's not something that we really expect to happen. So ergodicity is hard to find. You can see it in electrons and electromagnetic fields. You can see it in planets and planetary systems. Human behavior, though, not so much. There's a beautiful paper. Some of you may be familiar with this. Borkenau and Ossendorf, 1998. They took a 30-item measure for the 5-factor model. So openness, conscientiousness, extroversion, agreeableness, neuroticism. And they gave it to 22 individuals on 90 consecutive days. Now, the 5-factor model, I assume most people are familiar with it. Just in case anyone isn't, it's just one of the most widely replicated models of personality that are out there. It's been shown in clinical populations, student populations, prison populations, and cultures all across the world. It's a very robust and well-replicated model. So now when Borkenau and Ossendorf, when they aggregated across their 22 subjects, they also found evidence for the 5-factor model. No problem. Great model fit. They found what everyone else has found for decades. However, in that they gave the data to the 22 individuals on 90 consecutive days, they were able to do something called P technique, which I'm going to talk about in a little bit, which is where it's a fancy term for a relatively simple idea. You just take individual data and subject it to factor analysis, much like you would subject group-level data to factor analysis. Because here, your sample size, instead of being 90 individuals, is 90 observations. And so when they did this, they found very interesting results. They found no replication of the 5-factor model. There were 1-factor solutions, 2-factor solutions. There was a 5-factor solution, but it didn't look anything like the 5-factor model as we know it. So the idea becomes that there may be characterizations that we have of phenomena, of psychopathology, of psychotherapy process, of psychotherapy outcome, that are emergent factors, that are emergent properties. It's only one study, so it's probably an overstatement, but I think it can be at least offered as a potential hypothesis that the 5-factor model itself might be an emergent property of group-level aggregation. I don't actually think that's the case. I mean, I was asked a question about this recently when I gave this talk, and what I really think is it's something that characterizes differences between people, but doesn't characterize the variation within any one of us over time in terms of, I might have a balance of neuroticism versus extroversion that is characterizable when you compare it to the balance that you have. But as you look at my behavior day to day to day, the constructs of extroversion and neuroticism and openness don't adequately encapsulate or reflect or characterize the variation in my behavior in the same way. So it's like we have kind of maybe these somewhat quasi-absolute levels within us, but then they don't characterize how we behave differently day to day. I mean, I'm getting myself a little off of track there, sorry. It's hard with just talking at a computer. There's nobody to interrupt me. Okay, so why should we worry about this? So this is really the key thing. So the idea is that I would argue, and I've already kind of said this a little bit today, that everything is time varying. Even if we measure it cross-sectionally, we're taking a snapshot of something that's varying in time. So we want to have some confidence that anything that we've measured at one point in time is going to actually predict later behavior. And here's where we get to the idea of, we were looking at that slide a minute ago with all the different trajectories, and I was making the point about that grand mean trajectory might characterize the group, but it might do a very poor job of characterizing any individual that composes the group. Well, this idea of ergodicity then, to take that a step further, tells us that if we have some group level finding, some group derived conclusion about our data, we may have poor confidence about the degree to which that actually talks about a process happening in an individual. And as this is SPR, and many or most of us are very concerned with psychotherapy and how it functions, I think that that has very large implications for psychotherapy. If we base our conclusions, our understanding of psychotherapy, how it works, why it works, consistently on group level information, we may, and again we may be running the risk of doing a poor job characterizing the changes and processes within any given real individual, and thus making conclusions that might not relate to individuals and how they actually function. Again, I just offer that as a potential danger in how we approach things. So this is just a little spiel here about taking this temporal dynamics idea, adding just another little piece to it, that we can think of psychopathology as something that's kind of organic, and living and breathing to some degree. And I have this quote from the DSM to show that there are ways that we maybe are already thinking this way and we don't even realize it. That we look at psychopathology as a syndrome or pattern where you have these maladaptive patterns that are causing significant distress. The word pattern itself kind of infers a dynamic process, that there are these temporal dynamics, that when you have a pattern, you have a sequence, and that sequence follows some order, and the order is inferred to be in time, that I feel this way, then I feel this way, and my feelings kind of map on to my behavior in this way, and thus that's why I'm anxious, or that's why I'm depressed. So in psychotherapy, we might argue, I see that my text here is very declarative, I soften it a little bit, we might argue that we're trying to interrupt patterns and trying to help people have more adaptive patterns of thoughts and feelings and action. So, all right, so try to shift into some data analyses and try to keep this very straightforward. So I'm going to be showing basically two different types of approaches to looking at data. And I'm going to put the cart before the horse just a little bit here. So I'm going to be talking about P technique, which is, as I mentioned a moment ago, is a way of data reduction, factor analysis on individual level data. And that's often a first step before getting to what I'm now going to talk about, what's called dynamic factor analysis. But I have this slide mocked up, and I think it's a nice introduction, and it follows from this idea of temporal dynamics. I just want to jump in here. So what we can do, let's assume that we have the resources and we've been able to measure quite a bit of data in our individuals. And this is happening more and more with smartphone technology, and I know that there are folks out there who are setting up their clinics with computers for people to check in every time they have a session. And so this is starting to happen, that we're starting to get a density of data. If we can have enough data, we can start to look at some ways of encapsulating these or representing these potential dynamics in an individual. What we have to understand, though, is we have to change our orientation to what our sample is, what our sample size is. And I mentioned this a moment ago, that instead of individuals, our sample size now becomes time points. And unlike a mixed effect model or a latent growth model, those time points are not going to have a sensible order. 0 followed by 1, followed by 2, followed by 3, because we're going to aggregate across them. Just like when we do statistical analysis of our groups, we aggregate across individuals in our groups. So here we're going to be aggregating across time points. And thus, as we represent time, we represent it in this way that we call t minus 1 and t. Sometimes you'll see it as t and t plus 1. So the idea here is that we're looking at a given day and a given following day. And if you see here, the data that I'm showing on this slide came from 112 consecutive days. So what has been done here is that there's been an aggregation of day 1 to 2, 2 to 3, 3 to 4, 4 to 5, 5 to 6, and so on and so forth, that we then represent the average day-to-day relationships. Now, in addition to that, this data is a really nice place to start in talking about these types of models, because here, this data had the added benefit of being collected 3 times per day. So we have morning, midday, and evening data. So what we can begin to do, and what I want to try to orient you to first, is we can represent a given day-to-day relationship for this person. Now, these data were very simple data. They were a 0 to 100 scale, and participants were asked to rate simply their general level of worry and anxiety. So this was from a generalized anxiety disorder cognitive behavioral therapy trial. So 3 times a day, just a single number, 0 to 100, and in the morning, the midday, and the evening. And representing this in a, to use the words that Kim used when she introduced me, a multivariate time series analysis, what we're doing is looking at the relationships between the first day and the second day, where these represent any 2 consecutive days aggregated over 112 days. Now, there are several different ways to approach looking at data like this. You can bring a priori hypotheses into it and use a confirmatory factor analysis to test whether your hypotheses are met. What I use with these data is, because I feel that this is an openly and admittedly exploratory process, I use something called an automatic search function that's available in Listral. And it uses a Lagrange multiplier test, and it's not as complicated as it might sound. The program is able to look at the chi-square statistic and examine what path can I add. So if we have no assumptions and no paths, and here I know I have my slide set up to add all of them, I apologize, but what path could I add? Let's say it's this one, that would reduce the chi-square by the greatest amount significantly. And you can just, with an automatic search function, you can set up the program to keep adding paths until there are no more significant reductions in chi-square available. And so inevitably it tends to create well-fitting models for that reason. But what you can get then is you get a schematic of the day-to-day relationships in a person's anxiety, for instance. And then, of course, because you're working in a structural equation modeling framework, the relative strengths of those relationships. So these are standardized regression weights. So they have a maximum of 1 or negative 1 and a minimum of 0. So there's a lot going on here, but what I want to direct your attention to are these 3 relationships, because here's where I want to try to transition us towards this idea of a person-specific psychotherapy. If I had these data and I am this person's therapist, I know that their evening level of anxiety, let me get a little, so their evening anxiety here is going to predict their morning level at 0.54, their midday level at 0.47, and even their next evening at 0.26. So if I know that evening anxiety level, or more importantly, I think I should say actually, if I know the things that contribute to that evening anxiety level, how do they decompress from their day? What does their sleep look like? What's their sleep hygiene? What are their sleep habits? What's going on for this individual in the evening? If I can draw down that evening anxiety, I'm going to have a cascading effect on the next day's anxiety, which will inevitably then reduce the next evening's, and so on and so forth. And so you can see that with this kind of data, there's the potential, there's the possibility for having person-specific, idiosyncratic data, information about how this person functions and how their impairment actually looks, and thus how you might target a specified intervention for this individual. So right now, in this study that I just, this has been published in JCCP a couple of years ago now. In this study, the data were collected during therapy. This was information that was across therapy, so the idea of having this, equipping the therapist with this information at the beginning of therapy wasn't possible. So for that reason, I wanted to go about creating a study and testing the possibility that one could collect this kind of information before therapy even starts and try to go about creating a person-specific model of psychotherapy intervention. So in the study right now, it's being run here at Stanford University. Includes a baseline standard assessment. We also do a neuropsychological assessment. I won't talk about that right now. Structured clinical interview, which is the ATIS, if people are familiar with that. We then have a 60-day pre-therapy data collection period, and it's been amazing. People have actually done a great job with this. It's pretty simple. I'm not using smartphones or anything like that. I have a web-based daily survey and send it out every day at 7 a.m. It's automated and it gets sent out for me, and it's encrypted and all that kind of stuff. And so the people get it in their email, they click on the link, and they fill it out once a day. And people have been doing a great job with this. So I get daily information for 60 days. And then we give them 12 weeks of cognitive behavioral therapy for GAD, and we continue the daily assessments. And then, of course, at the end of treatment, we do the standard assessment again. So now this is, I should say, and I'm going to talk about generalized anxiety disorder in just a moment, this is a generalized anxiety disorder study. One of the hypotheses is that there will be variability in the degree to which worry actually influences the other symptoms in GAD. And I think this is actually a really important place to start because worry is often treated synonymously with GAD. People kind of think and talk and represent the two as the same thing, but there are a number of other symptoms in GAD. And it occurred to me, it seemed really important to directly test that. Is worry really driving everything else, or does it coexist with these other symptoms, or is it driven by other symptoms? And I think that that's something that I wanted to directly test. And this is something that I, for sake of time, didn't talk about earlier, but there's some data that shows that GAD responds less well to cognitive behavioral treatments compared to other disorders like panic disorder or post-traumatic stress disorder. And I do think that the degree to which worry is kind of the driving factor might predict that degree of treatment response. I'm not going to elaborate on that too much, but if people have questions, I'm more than happy to talk about what my thoughts are there. So the data analytic plan, take the 60 days of data, do a P technique, person-specific factor structure. Talk a little bit more about that in a second. Do these dynamic factor models, so hopefully we feel at least somewhat comfortable with what those models are and what they look like from the earlier slide, and I'll show you a few more slides of that. And then get to a group level analysis in the difference of these dynamics between people in predicting distress, impairment, outcome, etc. I don't have enough data at this point to talk about that, but it is going to ultimately be part of the study in the long run. So what is P technique? Again, it's a within-person factor analysis. So we want to take large amounts of data and reduce them down to smaller, more workable components or units. As I noted before, the sample size is going to be the observations within a person. So these are observations over time as opposed to observations across people. And what the beauty of this is, in my opinion, is that because this happened over time, once you've done your P technique and identified your factors, these factors are factors that you've measured over time. And so then you can make the step to the dynamic models and look at the way that these factors relate to each other over time. So GAD, excessive anxiety and worry, more days than not, at least 6 months, about a number of events or activities. So the worry has to be difficult to control, and it has to be associated with 3 or more of these following symptoms. Now, there was available online for a little while a whole other set of proposed symptoms for DSM-5. Those have been pulled offline. I don't know exactly what's happening. But this is the full list here. We don't have to dwell on this slide, but this is the full list of the DSM-4 symptoms and the DSM-5 symptoms. And the DSM-5 symptoms tend to be more behaviorally oriented, avoidance of negative events, time preparing for possible negative outcomes or events, procrastination, reassurance seeking. But this is the total list now of the actual DSM-4 and at least what were for a while up on the DSM-5 site proposed as DSM-5 editions. And this is all, of course, in addition to worry, which needs to be severe and upsetting and difficult to control, etc. So what we can do is do a P technique, do a factor analysis, because these are a lot of symptoms. And if I wanted to do a dynamic model of the way all of these symptoms relate to each other, that's going to be a bit overwhelming. It's going to be a lot of information. How do I even interpret it? So a nice place to start is with a P technique. So this is one of our participants, and for this participant there was a 3-factor solution. Here are the factor loadings. For those of you who are familiar with factor analysis, you can see these are nice, strong loadings. No loading smaller than 0.85 on the worry factor, 0.89 to 0.69 on this self-doubt and distraction factor, and 0.9 to 0.69 on stress and fatigue. So we have a self-doubt factor composed of procrastination, reassurance seeking, difficulty concentrating, avoiding activities, and then it seems some irritability that comes along for the ride as well. And then stress and fatigue, difficulty sleeping, muscle tension, easily fatigued, and restlessness. And all of the worry, facets of worry, load on a worry factor. Okay, so we've now effectively reduced the amount of data from all of these symptoms, and a couple symptoms also got kicked out, didn't load on any of the factors. So now we can look at the dynamic factor model. So we look at these symptom dynamics here day to day. We can look at these curved lines or the correlations within a day. These initial lines are what we call stabilities. This is the degree to which any one symptom group predicts itself. And then I think what is, to me, the most interesting piece, these are the cross relationships, the degree to which one symptom cluster might drive changes in another. And for this person, what we see is that their degree of stress and fatigue is driving the variation in their worry. And in turn, their worry drives the variation in their self-doubt and distraction. Now, this individual is a successful lawyer, and self-doubt and distraction is one of the primary complaints that this person has, that their productivity is suffering, and thus their job is being compromised by the degree of self-doubt that they have and how distracted they are and their productivity. And so we have been working with this person, the therapist who's working for me, who I'm supervising, in targeting their degree of stress and fatigue and trying to work on sleep and improving sleep and being more rested and all of these types of things, as well as the more typical interventions that we give as part of the cognitive behavioral therapy for targeting worry to try to help this person. For those of you who are familiar and interested, it's a fantastic fit to the model. Okay, I just want to present one more of these and try to finish up so we can leave some time for questions if anyone has any. So this is another participant. And here we see a 4-factor solution instead of a 3-factor solution. And similarly, strong loadings. Here we have a behavioral avoidance factor, a cognitive avoidance factor, and an irritability and fatigue factor in addition to worry. And for this person, what's interesting is that the cognitive avoidance seems to be relatively stable, 0.52, but kind of on an island to itself. We see the correlations here, not very strong correlations with the other factors. In fact, cognitive avoidance, surprisingly, only a 0.13 correlation with worry. I'd actually be curious to talk about these data with Tom Borkovic, as Tom really thinks of worry as a cognitive avoidance process. But we see the cognitive avoidance is kind of apart from the other factors. But again, the cognitive avoidance, it had strong loadings on preparing for negative outcomes and reassurance seeking, and relatively stable, 0.52. So this is a real phenomenon for this person, but it seems to be unrelated to the rest of their psychopathology or their presentation. The behavioral avoidance, though, is the most stable of the factors and is driving this individual's worry. Now, there's this interesting relationship here, and in fact, to give you a little peek into this person's therapy, right now the therapist is actually trying to unpack this. Is this a spurious piece of information? That's my hypothesis, honestly, that this is not something meaningful. Because the interpretation here is that as this person gets less irritable and more well-rested, they exhibit greater behavioral avoidance. So, which is a confusing thing. It's not a strong loading. And so we're actually kind of teasing that out in the therapy right now. The thing that really jumps out at me, though, is that as this person exhibits greater behavioral avoidance, that drives up their worry. And behavioral avoidance and worry cross-sectionally are correlated quite highly. So within time t-1, a 0.77, and then what these t correlations are, this second time point, you can think of this as like a really big, complicated multiple regression, right? And we often talk about in regressions partialing out or controlling for other factors or other features of the regression. But that's exactly what's going on here. So when you look at this 0.44 right here, this is the correlation between behavioral avoidance and worry, controlling for the autoregression of behavioral avoidance, the autoregression of worry, and this cross-lag behavior, and then all of the other parameters as well, but really most importantly these 3 factors. So it's kind of, this is like a partial correlation in that regard. And it's interesting to see that even after controlling for all of that other stuff, that we still get a relatively strong relationship. So for this individual, behavioral avoidance and worry are very tightly related, and we do see evidence for this time-lagged causal relationship, that greater behavioral avoidance is generating greater worry for this individual. Now, the fit for this model was not quite as good. We do have a non-significant chi-square. The RMSEA and the SRMR are not quite where we want them to be. The CFI is strong, so we've got 2 fit indices that are strong and 2 that are not. These are the a priori. These are the fit indices I selected before the study began. So, there are some possible reasons for that. Often when you have models with a lot of weak relationships, it demonstrates poor degree of the model you've created in the way it relates to the underlying variance-covariance matrix. So certainly I could probably improve this fit by fixing some of these relationships to 0. But nevertheless, it's a good enough fit, and I feel good about this model, and we have been using it to inform the therapy of this participant. So at that point, gone for about an hour, if people have questions, shoot.
All right. Aaron, so far we don't have any questions from the audience, but usually it takes a little while for people to come up with something, so that's fine. Thank you for a very interesting talk. We're just going to have to wait for people to ask some questions for a little bit. Meanwhile, I have a question that I was thinking about. And that is the subject of error. So you show these models, and as far as I can see, there's not something like an error structure or something like that built into that. I don't know, is that in the P technique or the dynamic state models?
Yeah, there's plenty of error. I mean, so these are, with the P technique, you have measurement error. So different people take different approaches to doing factor analysis. It's an interesting thing, and if anybody's curious about this, I've actually just been reading about this, so I have some papers at the tip of my tongue or tip of my fingers, whatever I could send along. Most of the time when people do factor analysis exploratory, they do principal components analysis where there isn't a partialing of measurement error. You just you use all available whatever variance, for looking at the different components. Whereas the true exploratory factor analysis with like a maximum likelihood absolutely has, a fit and measurement error. And so what I've been using is I use exploratory factor analysis, and yeah, there's measurement error attached to the observed variables. And in the dynamic models, here I'll kind of track back. Let me go to the other ones, a little easier to look at. There are errors here. There are latent errors on these factors that I just didn't provide. Since I can just use my computer, right? You can all just see what I'm doing here. I will show you. So let's see. So this. So for instance, okay, so let's look at person 2. And oh shoot, which one? Now you're seeing behind the screen. Which one was the final model? I don't know. Well, here we go. Here's a model for this person. And these are literal output. I don't know if people are familiar with literal, but I will show you the error. Yeah, this was the final model. So. Okay, here's the standardized output. These are it's not quite as easy to interpret as, the schematic I drew. These are those regression relationships. And down here, we have across the diagonal are the errors. Now, they are standardized at 1 in time t minus 1 because there's nothing informing those latent structures. But here we see at t minus 2, we have variability in the error in the latent variables. The interpretability of that is kind of hard to discuss, and I don't think I'll get into that. But the long story short, yes, there is absolutely error associated with these models. I hope that was helpful.
Yes, it was. There's also a question from Javier Prado from Spain. Although he says, very interesting, Dr. Fisher, greetings from Spain. I'm not sure if he has an actual question. Let me just open up his microphone to see if that's true. Javier? Yeah. You can talk now. All right, so probably not.
Okay.
All right. So, Aaron, it seems that we currently don't have any questions. So, I guess we can round things up right now. And I want to thank you for showing us your work. And I'm very confident that you will have a very bright future in the field of psychotherapy research and continue to do this very interesting work. Oh, there's a question coming in just now. All right, it's from David Casson. David, I'm going to open your microphone right now. Go ahead. David, if you have a microphone, you can ask your question in person.
Hi, can you hear me?
We can hear you.
Yes, I just would like to know what is Dr. Fisher's primary theoretical orientation, and among the therapists that he might supervise, is there variation there as well, and are you seeing any differences in how this model helps predict psychotherapy planning?
Yeah, that's a great question. So for me, I identify myself as a cognitive behavioral therapist, but I was very lucky in going to Penn State. Little plug for Penn State here. I got really great psychodynamic training as well. So I really kind of think of myself as a bit of both, but certainly here at Stanford, in the department I'm working in now, tends to be more of a cognitive behavioral orientation, and I've been supervising under that theoretical direction. So the other thing that needs to be stated here is that I didn't want to go too far in this direction. I didn't want to take too great a risk. So we are leaning on a manualized therapy. We're using the one by Michelle Krask and Dave Barlow, the Mastery of Anxiety and Worry, and we're kind of using that as like a baseline, like what we're pivoting off of, and then kind of tweaking based on what we're seeing with the data. And the therapists I'm working with are third-year graduate students here, and they're mostly, almost exclusively trained in cognitive behavioral therapy. So we don't have a lot of variability really to speak to there. But it's a fantastic question because I think that this kind of way of thinking, conceptually at least, might map onto some theoretical orientations maybe a little bit better than others. And that would be interesting to actually play with empirically at some point, definitely.
Thank you very much.
No problem.
All right, so Aaron, I think unless we have a question right now, doesn't seem like we do, we're gonna round it up. And again, thank you for your time and your interesting presentation. And for those of you who want to see it again, it will be posted on the SPR website, where you can actually see it and show it to anyone you like, as it's not password protected, and so you can just share this presentation. 1 second, Aaron, I'm just going to mute you for 1 second, just to get rid of the static. The next webinar will be again in the Distinguished Researchers series, and it will be Professor Lorna Smith-Benjamin, and she'll be talking about false beliefs in clinical psychology and psychotherapy, which promises to be a very interesting topic. So we're hoping that all of you are coming, and we'll see you again for the next webinar.